Monoclonal antibodies are manufactured in a lab and are not derived from human blood products. These medicines are antibodies that work against a protein needed by the virus, which causes COVID-19 to enter cells in the body. When the U.S. Food and Drug Administration first issued an emergency use authorization in December of 2020, there was a high demand, but IV infusion availability was scarce. Intermountain Healthcare has since used a risk-adapted approach to identify COVID-19 patients who will likely see benefits from this treatment.
Monoclonal antibodies for COVID-19 are an infusion-based treatment that are designed to stick to and to neutralize the SARS-CoV-2 virus. They are patterned after the body's natural response to viruses, and they work best when given very early on in the symptom course when the impact of the virus is at its greatest, and in patients who have no antibodies to the virus itself on their own.
During studies conducted on 1,300 high-risk patients, IHC saw a 57% rate reduction in those needing hospitalization and less mortality rates. Researchers found that only about 1% of those treated had complications from it.
Of the three products, because of more reliable activity against the current variants of concern, we're just using one of the products, casirivimab, imdevimab. And that drug is widely available. The limiting feature is that these drugs must be administered through an intravenous infusion. And they have to be administered in settings where that can be done safely by experienced healthcare providers.
Dr. Webb said the infusions take about 60 hours. It's critical they are administered at the onset of the virus in order to prevent severe illness, hospitalization, or even death in these patients.
We found that we were able to connect them with treatment very quickly after their test resulted positive, for most patients within about 2 days. And in that way, we were effective in targeting patients when they were still within that 7-day window where these drugs work the best.
Dr. Webb said these medicines are not the same as the vaccine and are for those who are unvaccinated and at high risk.
From the trials, we understand that patients who already have antibodies against COVID-19 are less likely to benefit from monoclonal antibody therapy, and patients who are unvaccinated, who are at high risk, and who are very early in their course are the patients who are most likely to get maximum benefit from monoclonal therapy. That said, there are high-risk populations like the severely immunocompromised, patients who have undergone solid organ or bone marrow transplant, oncology patients undergoing chemotherapy, etc., who would benefit from post-exposure prophylaxis under the new expanded EUA.
However, doctors say vaccinations are still the most effective way to prevent severe disease and death. Patients who test positive for COVID-19 and score high on the risk calculator are eligible for treatment. Patients may also be referred for treatment by a healthcare provider. IHC said no patient along the I-15 corridor in Utah is more than an hour drive from a treatment center. Currently, the drug costs are paid for by the federal government. However, there are infusion-related costs that most healthcare insurances will cover. Webb said more studies will be conducted in the future on the effect of vaccinated individuals with COVID.
It's very important that we have a better understanding of whether these products work in patients who have been fully vaccinated. And to that end, we're working with other healthcare systems, including Mayo Clinic, to gather data in a national registry sponsored by the Department of Health and Human Services to answer some of those important questions.
Melissa Anderson, Community Education News.